we're moving on with the blood vessels. Okay, we've gone through the blood, we've gone through the constituents, what the blood is made up of. We've gone through the heart, how the blood pumps. Now we go through how it goes through the rest of your body. This consists of your veins and your arteries, as well as your capillaries. Your capillaries are your smallest blood vessels, and they connect the arteries to the veins. They're like the passageway, they're the alleyways through the system. Arteries carry blood away from the heart. Veins carry it to the heart. When we are looking at the pulmonary vessels, do not equate oxygenated blood with arteries and deoxygenated blood with veins, because it's the reverse with the pulmonary vessels. The pulmonary arteries carry deoxygenated blood to the lungs, and the pulmonary veins carry oxygenated blood away from the lungs back into the heart. So when we look at this under a micrograph, it kind of looks really cool. So you can see, now this is in the thyroid. Remember, the thyroid, when we're looking at those endocrine glands, has massive blood supply, right? Well, we can see this here. We can see all of these capillary beds surrounding those follicles to be able to uptake thyroid hormone, T3 and T4. The other thing that we see is we see layers of smooth muscle around the vessels. Why do you think we have smooth muscle that surrounds these vessels? So what happens when you are relaxed and digesting a nice meal? You get tired, yes. Let's focus on the blood vessels. Your vessels expand to allow for the uptake of nutrients within your digestive tract, right? They do that through smooth muscle relaxing. But when the big scary bear or the dinosaur comes and wants to eat you as lunch, all of a sudden, those vessels are going to contract and close down blood flow to the digestive tract and the urinary system. And it's going to shunt it to your brain and your muscles and your heart. So you have smooth muscles surrounding all of your vessels to allow for changes in your body. So when we look at the walls, we see that there's layers, okay? You've got three main layers. You've got the inside, okay? The inside that lines the lumen of the blood vessels are called the tunica interna. What structure in the heart did we just look at that would be equivalent to the tunica interna? Yes. Yes. The endocardium, that inside lining, is continuous with the tunica interna, because you don't want that turbulence. You don't want to have a seam between your heart and your blood vessels, because then that's going to give platelets a place to stick and cause stenosis or a narrowing of those vessels. The next layer out is your tunica media, okay? And then outside of that, covering it all, is your tunica externa. So let's look specifically at the tunica interna. This is the layer that's exposed to the blood. It's made up of simple squamous because it's permeable. You've got movement across those membranes, across that epithelium, okay? But you also have secretion that happens here, because you have secretion that reacts to what's happening in the blood that will either cause for dilation or constriction of those blood vessels. You don't want them sticky, You want it to be a nonstick surface. So there is that normal repellent of platelets and blood vessels to prevent clotting, to keep that nice and smooth. When you have a swelling, what you find is those endothelial cells in that tunica media will secrete substances that make them stickier, okay? Basically, it's a substance, it's a chemical substance that calls to the leukocytes and allows leukocytes to adhere to that surface, to come into that area to clean up whatever may be causing that inflammation. When you have inflammation, it's not from the tunica interna, it's from something external that the body is reacting to. Okay, any questions on that? Your middle layer, tunica media, that's your smooth muscle layer. That is the layer that we see here around those blood vessels. Okay, so this is an artery and this is a vein right here. And you can see the difference. You can see that the artery has a thicker wall than the vein. And you can see that this tunica media makes up a big portion of that wall. This is what helps the blood vessels respond or resist the pressure within the blood vessels. Remember, when your heart is pumping, your pressure is going to go up to 120, 130, 140, 150, or if you have really high blood pressure, 180. That's a lot of pressure. And your blood vessels need to be able to withstand that. So the tunica media, or these smooth muscle layers, helps your body to withstand that. When you need to have vasoconstriction for some reason, that tunica media will constrict down and contract to decrease the diameter of that blood vessel. And then your outermost layer, okay? This is that connective tissue layer that holds it in place. It connects out with the other nerves or the other blood vessels. So when you're in anatomy, there's a concept, there's something called a VAN, a V-A-N, because when you are dissecting a cadaver, what you typically find is the veins, the arteries, and the nerves always run together. So you always look for the VAN. Okay, that tunica externa is what helps to hold that VAN together. It also helps it to hold in place so that it's not like that wild hose flopping all over the place when you turn that hose up all the way in the summertime and you get the hose going everywhere. It prevents that. It also has small, tiny blood vessels, because think about it. You've got smooth muscle that surrounds it in the tunica media. You need to have a supply of nutrients and oxygen to those smooth muscles, right? So that tunica externa is where those tiny little blood vessels that supply the vessel themselves with blood, that's where they all live as well. Any questions on that? Much like the heart supplying the body with blood, the heart itself needs to be supplied. It's the same thing with the blood vessels. The blood vessels need their own blood supply as well. So when we look at this, and I've broken this up a little bit, we classify the blood vessels by size. We're going to start leaving the heart. You've got your large conducting arteries. These are your largest arteries. You've got then your distributing or your medium arteries, your arterioles that go into the capillaries. On the other side, you've got your venules, your medium veins, and then your large veins going back into the heart. You also have your conducting arteries, or those large arteries, also referred to as elastic arteries, because there's a lot more elastic tissue. Remember, the pressure differences in your arteries is going to be a lot different than the pressure differences in your veins. Okay, so those changes are going to be huge. And with each beat of your heart, pressure goes up and down. So those arteries are going to need to be able to bounce back to their original shape. There's lots of elastic fibers in there. Your medium arteries and your muscular arteries are also known as your distributing arteries. Your small arterioles are resistance arteries also. And then another concept is in capillary beds, there's kind of like a main street. So you've got all the little capillaries on the other side, but you do have a main street on many capillary beds. That's also a meta-arteriole, which is a thoroughfare channel that goes through a capillary bed that can turn on or turn off those capillaries as needed. So let's look at the conducting arteries, the very first ones. They are the biggest. This is your aorta. This is your carotid arteries, your subclavian, your pulmonary vessels, pulmonary trunk. When we look at the structure itself, okay, so you have the lumen and you have that endothelium, okay? Underneath the endothelium is the basement membrane, which consists of your tunica interna. Then you've got this tunica media, okay? Lots of elastic tissues. Remember the forces that are happening there. And you see an elastic lamina at the border between the tunica media and the tunica externa. They expand during systole and recoil. Distributing arteries, these are the arteries that go to specific organs. So your distributing arteries are going to distribute the splenic arteries, the brachial arteries, the renal arteries, the femoral arteries. These are distributing out to the specific areas. These distributing arteries are also huge on the smooth muscle layers. 3/4 of the diameter of the vessel consists of smooth muscle. In your arterioles, okay, these are the smallest of your resistance arteries. There's only 1 to 2 layers of smooth muscle. Again, when you're comparing the lumen of the vessel to the thickness of that tunica media or that smooth muscle layer, it's very, very close. There's very little externa. There's very little of that layer to hold it. So when you're looking at the externa, it's really, really thin, but when you're looking at that tunica media, it's much thicker. If you have a large tunica media, a large layer of smooth muscle, what do you think these arterioles are going to be doing? Remember, the tunica media is that smooth muscle layer. What is the smooth muscle doing on blood vessels? It's facilitating the contraction and the, right. So that smooth muscle layer is responsible for contracting to close down and vasoconstrict or relax and vasodilate. So this controls how much blood goes to that area it's heading to. This is what I was talking about with the meta-arterioles. So you've got the arterioles, and then you've got this offshoot. This is the main street, and these are all the side streets off of Main Street, okay? They link arterioles to venules, and they typically have capillary beds that are off on the side of them. So they provide a shortcut for blood to go from arterial to venule. And it also can either close down those capillary beds if you don't need to have blood perfusing it, or turns them on as the body needs. Let me give you an example of this. Somebody says something to you that is incredibly embarrassing and your face turns bright red, right? I know mine does. My ears too. My ears go red. Your venules and your arteries are connected through these meta-arterioles. They're typically turned off until somebody says something embarrassing, and then they open up and your face perfuses with blood. And then the embarrassment goes away and your face, the blood goes away. You're not red any longer. Those meta-arterioles, again, shut down that thoroughfare or those side streets of the capillaries. Does everybody see that? Okay. When we're looking at blood vessels, we know that atherosclerosis exists, right? When you have a bulging sac, so actually my grandfather passed away from a ruptured aortic aneurysm, and it's very common. This is probably one of the most common issues that you see in elderly patients today. Basically, due to atherosclerosis, what you find is you find that the vessel will expand and the layers begin to separate. So it forms this balloon within that blood vessel. It becomes a thin-walled sac. And you can see this aneurysm right here. This is huge. These are your common iliac arteries, and this is the aorta. Those aneurysms or those balloons are a ticking time bomb. They can rupture at any time. When my grandfather was first diagnosed with his aneurysm, it was I think they said it was a 6-centimeter aneurysm. And at the time, they gave him anywhere up to a year before it ruptured. Well, 10 years later, it grew to be about the size of 11 centimeters, which was huge, and it did rupture. Every patient is different. He was inoperable. He had so many other health issues at that point in time. We're surprised he lasted as long as he did, which is great because he got to meet 2 of his grandchildren. When you have an aneurysm that has that blood accumulating between those layers, now remember, this is a balloon, and I said that those layers will separate out, right? When you have blood that starts to pool within those layers, it's called a dissecting aneurysm. Because what happens is with that pooling of blood, that tunica media can't really do its job anymore. Because it's not being used and not doing what it's supposed to do, it begins to degenerate. The most common sites of these aneurysms are the abdominal aorta, the renal arteries, and the circle of Willis. The circle of Willis lives in the brain. You will know about the circle of Willis by the end of the week. If you put pressure, so my grandfather was a really big guy. I mean, big, big belly. If you pressed on his belly, it caused him pain because putting pressure on these aneurysms or in the area of an aneurysm will cause discomfort for the patient. When you have a rupture of these aneurysms, they rupture quickly. My grandfather, when his ruptured, they suspect he bled out in 20 seconds. It happens fast. It is the result of a weakness in those blood vessels. Here's another example for you. Trauma can cause it as well, and then bacterial infections. Atherosclerosis is one of the most common causes of this. My father-in-law, when he was 30 years old, they found that he had a ruptured He had a rupturing aneurysm in his circle of Willis. He had one of these in his circle of Willis, but they found it in enough time and he survived. Talk about a miracle. I don't know what kind of luck he had to survive that, but he did. It is a congenital weakness. So what they do is then they monitor children of that patient for these types of weaknesses within their blood vessels. Okay. Within the arteries, we're still working with arteries. We haven't gotten to the veins yet. Within the arteries, you have sensory structures that tell you what's going on in the blood. So it monitors the pressure of the blood pressure, but it also monitors blood chemistry. You have the carotid sinus, which is a baroreceptor. This is what's monitoring pressure. And you also have chemoreceptors, which we see in the carotid bodies and the aortic bodies. They basically take this information, transmit it to the brain so that the brain can then control what's happening, whether it's blood vessel diameter, whether it's our respirations or our heart rate. So let's take a look at where these are located. Your carotid sinus is located in the internal carotid artery. Okay, that's where your baroreceptors are. Remember, your internal carotid artery is going up into the brain. Why would it be so important to monitor the pressure of the blood that goes into the brain? Yes. Right. So the brain is a delicate instrument and too much pressure can cause damage. So if the body senses that too much pressure is going into that brain from the internal carotid artery, it can take measures to reduce the pressure going into that brain. The carotid sinus transmits its signal through that glossopharyngeal nerve, going back to the nervous system from last year. Your carotid bodies are on the external carotid, okay? This is a chemistry. So it's monitoring, and basically it allows us, it's monitoring your blood pH, and it's allowing you to control and stabilize blood pH through your balance of carbon dioxide and oxygen within the blood. Again, it's the same area as that carotid sinus, which means it's going to go through that glossopharyngeal nerve. Yes. Changes what? Too great, yes. Huge changes in blood pH can make us sick. Okay. I think it depends on the degree to which it changes. So we have a range that we can survive as humans. It's a narrow range, but it's still a range. What's the range? The range is anywhere from 6.9 to 7.2. So it's a seriously narrow range. Beyond that, you will die. You won't necessarily die from the change in pH. What you'll have is a chain reaction going within your body that tries to adjust to that pH, and then that person destabilizes. You don't typically see massive changes like that unless you see huge injuries, huge infections. So when somebody is in ICU, that's actually one of the things that they're monitoring. They're monitoring that blood pH. So it does change, but not huge. So your teacher is right, but it's a matter of degree to which you're talking. So through that glossopharyngeal, your brain is monitoring that. So it's so much more complicated than just monitoring pH, because really what it's monitoring is it's monitoring hydrogen ion levels or hydrogen ion concentrations. And in those hydrogen ion concentrations, you can impact that based on how much you're breathing in. You can increase your respirations, which will change your ion concentrations within your blood. The other place that we see the chemoreceptors are in the aortic arch. So when you see these 3 blood vessels coming off, in between each of them, so in between that common, I can't believe I'm drawing a blank on that. The right subclavian, the common subclavian, the left common carotid, you've got one aortic body. And then between the left carotid and the left subclavian, you've got the second aortic body. They live in between those vessels. Okay, right on that aortic arch. You have other baroreceptors in that area as well. We're not going into that. Just know where your carotid bodies are, your aortic bodies, and your carotid sinus. Okay. All right. Now we go into capillaries. Capillaries are your exchange vessels. This is where you have that exchange of oxygen and carbon dioxide between tissues, as well as in the lungs. It's the business end. Okay. So we have an endothelium and a basal lamina, and not much else at the capillary level. Okay. You don't see capillaries in the cornea of your eye, the lens of your eye. You don't see them in ligaments. You don't see them in tendons, and you don't see them in the epithelium. Remember, the epithelium has no blood supply of its own. Question? Okay, there's 3 types of capillaries. You have got your continuous capillaries, which is what we most think of when we think of a capillary bed. We've got fenestrated capillaries, and we have sinusoids. So a continuous capillary is what you think it is. You've got tight junctions between the endothelial cells that have that continuous tube that allow for substances to pass through, like glucose. Around the outside, since you don't have smooth muscle, because these are your absorption sites, you do need to have a way to contract those capillaries if we need to. So we have something called a pericyte. A pericyte wraps around the outside, and it's a cell that has the contractile proteins of smooth muscle in it. They are responsible for regulating the flow in the capillaries. Anywhere else on that capillary, all you have is that endothelium and the basal lamina, because this is your site for exchange. Next, we have fenestrated capillaries. These are rapid filtration or absorption, okay? Basically, we see it in the kidneys and the small intestines. So what we have here is we've got those endothelial cells and the basement membrane, but those endothelial cells have a whole bunch of holes in them to make it easier for small molecules to pass through. So it makes sense that we're going to see these in our kidneys and in our digestive tract where we are absorbing nutrients. You won't see larger proteins leave through the fenestrated capillaries, but you will see smaller molecules. So if we look at this, I'll blow this up. Here is your endothelium, and then you've got the fenestration pores interspersed throughout the endothelium. When you look at it on the outside, you can see they are, I don't know if anybody's going to know what I'm talking about, but you ever see the kettles that have all the little holes punched in them? It's called rose malling. obscure little known fact, which I can be known for sometimes. So there's an art form where they would take these sheets and they would poke little holes in them. That's what that looks like to me, is where you've got the decorations in those metal sheets. Okay. On with my useless information. Next, we have sinusoids, okay? We see them in the liver, in the bone marrow, and in the spleen. Okay, so these are capillaries that are going to allow larger molecules or cells to actually be able to move through. They are basically these large cavernous spaces that allow for clotting factors to move through, blood cells to enter circulation. And basically you've got the endothelial cells and there's these huge spaces in between those endothelial cells. So in the fenestrated capillaries, you got the tiny little cells within the endothelial cells. In the sinusoids, you've got a big separation between all of the endothelial cells themselves. We see this in the bone marrow. Remember when we looked at the megakaryocytes and you had the megakaryocyte tail that entered into the bloodstream? This is where that's happening. That megakaryocyte's tail is in that sinusoid, and it's in between those endothelial cells, releasing its bits of platelet as the blood passes across it. We've already gone over capillary beds. We're going to go a little further in, okay? At any given time, 75% of our body's capillary beds are shut down. We're only using about 25% of our capillary beds within our body at one given time. We see that most of the control of these capillary beds are happening upstream at the arterioles. Hence, when we look at the arterioles and these sphincters, it's upstream that you have the control of the flow through those capillary beds. All right, veins. So we've gone to the capillary beds, now we're at the veins. They are thin-walled and they are loose or flaccid. When they collapse down easily, but then just as easily, they open up when blood flows through them. 64% of the blood in our body lives in our veins. So at any given time, 64% of our blood lives in our veins. Only 15% is in our arteries. Huge blood storage within our body. Remember, in arteries, you have the big differences in pressure. So with every beat of the heart, it goes up to 120 millimeters and down to 80. You don't have that in the veins. The farther away you get from the heart, the more steady the pressure becomes. It's kind of like getting on the highway. So I don't know if anybody else traveled this weekend, but we went up to Flagstaff to visit my son. Literally, every highway had a closure to get out of Phoenix this weekend. It was, I don't know who thinks this up, but they are not thinking very well or efficiently. So it's like when you are in a blood vessel, it narrows down, right? Lots of pressure, lots of cars going from 5 lanes down into 1 lane to get off the off ramp to skip the area that they've got it closed down, adding an hour onto your trip. On the other side of that, once you've gotten through, you've gotten down to those capillaries. On the other side of that, what's the pressure like on the other side of that closure? There is no pressure. It's really low because there's no cars. So think of these blood vessels and the pressure in these blood vessels like those constriction sites on the 101 or the 17. Whereas when you get to the other side of that construction, that blood pressure is very low. On average, arteries, you're looking at 80 on the low, 120 on the high. On average, in veins, it's only about 10. It's a huge drop in pressure. You have, after the capillaries, the post-capillary venules. You've got the muscular venules, the medium veins, the venous sinuses, and large veins. So post-capillary, these are your smallest veins, 10 to 20 millimeters in diameter. These are the veins that you're seeing an exchange of fluid within the tissues. So if you have swelling of your ankles, in order to take that up, they don't come, you don't reabsorb that fluid through your capillaries. You reabsorb that fluid through the venules themselves. So these post-capillary venules is where you have most of your fluid exchange with surrounding tissues. You've got a tunica interna with fibroblasts. There is no muscle around that tunica interna. So this is also where you see leukocytes that leave the blood to go out into those tissues. They don't leave through the capillaries because there's no place, there's no room for them, right? The only place that cells can leave the capillaries is in the spleen, the liver, and the kidneys, or the sinuses, the sinusoids. Fenestrated capillaries, no. Regular capillaries, I'm having trouble today. I'm sorry, I'm distracted. No, it's only in those venules where leukocytes can actually get through the pores to go out into the tissues to do their job of cleanup. At the same time, you also have uptake of the fluids that may have been pushed out earlier. You have muscular venules, okay? Capillaries, post-capillary venules where you have that fluid exchange, muscular venules, where you start to see the smooth layers come down and reestablish themselves in the blood vessels. Outside of that 1 to 2 layer of muscular or tunica media, those smooth muscle layers, you'll have a very thin tunica externa. Your medium vessels, up to 10 millimeters in diameter. We see these most commonly when somebody has varicose veins. These are where we start to see the valves. Because when you've got such a low blood pressure in those veins, how is that pressure, how is that blood going to get back up to the heart? You've got capillaries in your feet, and then you've got those post-capillary venules, and then you've got the medium veins that are heading up to your leg. Gravity's working against you, man. So in order to prevent backflow, to have these big, huge feet that blood can't get up, you have valves that are in place to prevent that backflow. When those valves give out, that's when we see varicose veins, because then you'll start to see pooling and raised areas of veins within the legs. The other thing that helps, remember, you're talking only 10 millimeters of mercury, 10 millimeters of pressure there, really, really low. The other thing that helps is every time you contract your leg, that compression of the skeletal muscle puts pressure on those veins or venules to push it further up towards the heart. And that is called the skeletal muscle pump. They can't do it by themselves. Yes.
Why does it say like when you're sitting on the floor for like so long of a time, like your foot goes numb or like your leg goes numb? Why does that happen?
Because you're putting pressure on the nerve. Remember the concept of van. Vans always run together. Veins, arteries, nerves. So if you're putting pressure, if you lose blood flow to the area, you're also putting pressure on the nerve. The numbness and the tingling come from pressure on that nerve. You're cutting off those signals, but you also invariably are going to put pressure on those blood vessels as well, because they all travel together. Make sense? Any questions? Any other questions? Okay, so venous sinuses, we see this in the heart, the carotid sinus, or the coronary sinus, right? That's a sinus. It's basically a pouch. There's no vasoconstriction that happens in these sinuses. They've got large lumens, so it's a wide open space, and there's no smooth muscle. The coronary sinus drains into what? Somebody tell me. We just went over this. Any takers? Where? The what? The coronary sinus? Yes. It drains back into the right atrium. You were so close. You were so close. It drains right back into the right atrium. The other place that you see this is you see this in the brain. So when we look at the brain, okay, we've got the arteries that supply the brain, which we're going to go over. But there's like, you've got this central large artery, and then it comes and gathers in the back here. Those are sinuses, which is why pressure to the brain is so important, because if pressure gets too high, these sinuses are super thin walled. What's going to happen if you have super high blood pressure going into your head? Kaboom! The sinuses are going to rupture and you will die, which everything we do is to avoid that. Yes. Yes, absolutely. And those sinuses are one of the most common places for those brain aneurysms. All right, take a breath. Oh, yes. There is a hereditary component to brain aneurysms. There's a hereditary component to all aneurysms. Anything else? No, I love questions. Questions are great. Okay. On a side note, do not leave until I've spoken about lab tomorrow. Okay, just remind me. All right, so large veins. These are your pulmonary veins. These are your internal jugular veins, bringing blood down from your brain. Your renal veins. We're not at the vena cava yet. We're right before that. We see about anywhere under 10 millimeters, okay? So you've got a thin tunica media, which means there's not a lot of smooth muscle happening here. But it's weird because there is. What you see is you see longitudinal layers, okay? So you see a thin tunica media. Remember, the tunica media has those smooth muscle layers that wrap around. If you're looking at the lumen here, it's wrapping around. But in these medium veins, you also have smooth muscle fibers that are running lengthwise in that tunica externa. And that's what differentiates the medium veins from the large veins. Okay, so you're what? Yes. So think about it this way. In your legs, okay, you've got the skeletal pump moving. You've got the contraction of those veins with the smooth muscle to try and pull along with the back, preventing backflow of the valves. Once you get into the abdomen, I want to say it's like a peristalsis, but it's not, because it's not as marked. It's not as obvious, but you have these longitudinal fibers that will contract to kind of push it up and assist in that pump up to the heart, because there's such a low pressure that it's really hard to get the blood up there. And there's several other different mechanisms that the body uses, because it uses almost like a siphon action. Once the blood starts flowing into the heart, has anybody, Okay, so I know I'm dating myself. Has anybody ever siphoned gas out of a gas tank? Yes, you are like the first person in 2 years that I've been asking about that knows what I'm talking about. So you watch these old movies, if you watch the old movies, and you put the hose into the gas tank and you suck it out until it comes, and then you got to quickly take it out of your mouth because gas tastes awful. And once it starts flowing and it starts pulling the liquid out. It's the same type of action with the atrium within the heart, that once the vein, once the blood starts coming up with each pump of the heartbeat, once it starts coming up, it just takes a mind of its own and just continues on and starts to pour out on itself. Does that make sense? Okay, and then there's another way, and I know I'm getting ahead of myself, which is so cool, that every time we breathe, it changes the pressure within our abdomen. Every time we talk, every time there's a pressure change within the abdomen, that pressure change also helps to push the blood from the vena cava up into the heart, assisting with that siphon action, as well as that longitudinal muscle within that tunica externa that helps to move that blood from the vena cava and those larger vessels into the atrium of the heart. Does that help paint that picture? I know I went totally nerdy on you, I'm sorry. Okay, this is a picture of varicose veins. If we go back to those medium-sized veins where those valves start, this is what those varicose veins, those valves break. Those cusps just don't work any longer. And then you start to see blood pooling further down. And you'll see those pretty little shapes on the legs. Varicose veins are a hereditary issue. They're a hereditary weakness within those veins, those vessels. But obesity, being overweight, contributes to that. Pregnancy, girls, I am so sorry. Pregnancy is a big factor in varicose veins. And then hemorrhoids, yay pregnancy again, hemorrhoids is just a form of varicose veins within the anal canal. Yes. It's done. Yeah, it is not reversible. Okay, so the simplest route goes from the heart to the arteries, to the arterioles, to the capillaries, the venules, the veins, and back to the heart. Looking at this, the blood only passes through one network of capillaries. Doesn't always happen this way, folks. You can have several beds of capillaries that it'll go through before it starts back up on its route to the heart. Or it could pass the capillaries altogether and forget it. So this is where we start to talk about the different types of capillary beds that we have. So the simplest route is one capillary bed. That's what we see on top here, okay? Next, we've got a portal system, which means it goes from arterial to capillary bed to another capillary bed to the venule, okay? That's called a portal system. We see this in the anterior and posterior pituitary. Going back to endocrine, that hypophyseal portal system, this is where we see this. We see it going from the intestines because you've got the capillaries in the intestines, and then it transfers to the capillaries in the liver, and then it continues back on up to the heart. And then we have the anastomoses. The anastomoses is basically having two vessels converge onto one another. This is where we start to look at those highway closures in our great city of Phoenix. So there's a couple of different types. You've got your arteriovenous anastomosis. This is also known as a shunt, okay? What we see is we see a bypass. You can have a capillary bed, but you can also see a bypass route that gets you away from that traffic. Okay, that's like what we did this weekend, taking the 60 to the 101. Actually, no, we took the 60 to the 10 to the 51 to go up to catch the 202 to avoid off of that traffic. That was our shunt that we took to avoid the capillary of all the construction. Yes. Yes, it is a diversion around. Okay. Venous anastomoses is where we see this most commonly. All right, this is your most common. Basically, one vein empties into another vein. And what's really, really cool is your body can create more of these anastomoses. We see it in bodybuilders. People who are real into weightlifting will have lots of blood vessels start to develop because their body is creating anastomosis to get the blood moving from those muscles. It's kind of cool. A venous anastomosis is less serious than arterial anastomosis. Because remember, on the venous side, you are increasing the routes available. In an arterial anastomosis, you're decreasing the number of routes available. And that brings us into an arterial anastomosis. So if we look here, we can see two arteries converging into one. This is before the roadblock. All those five lanes going down into those one lanes, that's like your arterial anastomosis. So you can see you've got these two arteries going into this one artery here. These two arteries going into this one artery. That's where you see that. Whereas on the venous anastomoses, you've got one artery converging and possibly going into two arteries. It's more of a web. Does everybody see that? Does that make sense? Good. Okay. So when we look at the pulmonary trunk, you've got the right pulmonary artery that goes to the superior, middle, and inferior lobar arteries. From the left pulmonary artery, there's only two lobes to the left lung, so it only goes to the superior and inferior lobar arteries. And that is where your pulmonary trunk. The pulmonary circuit is super simple. It goes pulmonary artery, alveolar capillaries, pulmonary vein, back to the heart. It's where we get into the systemic that we get into a lot more confusion. So when we look at this, we have got the pulmonary trunk here coming off of the right ventricle, dividing into the left and right pulmonary arteries. Remember, this is deoxygenated blood. Each of those pulmonary arteries then branch out into the lobar, superior, middle, and inferior lobar arteries. On the left pulmonary trunk, it's the superior and inferior because there's only two lobes. From the lobar arteries, you then go into the pulmonary arterioles that go out into those alveolar capillaries. Those alveolar capillaries are surrounding the alveoli so that you can have that exchange of gas. On the other side, you've got the venules going into the pulmonary veins, going back into the which atrium? Left atrium. It leaves from the right ventricle and comes back to the heart in the left atrium to go out to the body. Okay. All right, there is a lot. This is probably one of the most intense chapters. I am going to pause it here. And I'm going to apologize. We may talk a little bit about this tomorrow because there just is so much. But tomorrow is good And this brings me to talking about tomorrow, lab tomorrow. Lab tomorrow is our first dissection. How many of you realized that?